Hello, and welcome back to the Black and African American Health Reform Initiative. We're very excited today to launch a new topic area. Of course, most of you have been very much aware and participating in many of our other programs that include other aspects of healthcare. Today, we are delighted that we are launching Black Don't Crack, does it? And we have a beautiful panel of experts and key opinion leaders joining us to help us sort of march us through this discussion so that we can do as we have always tried to do away with some of the myth and make certain that we are embracing education and solid information within our communities and our spectrum of cultures. Clearly, you know, these have been some unprecedented times, or so have been described by many people, but for many of us here, the times seem like they have very much precedence. And so we find that some of the challenges we deal with as a community, while they may seem to have increased, we know that they're persistent. And so what we try to do here is focus on those things that we can control, those things that are within our wheelhouse and spectrum. So as we get started, I'd like to ask everyone, please, at least for the moment, to mute your lines. We will have some opportunity to ask questions toward the end, but at least for now, if you would just mute your lines. And I will do another unique thing here that I know that many of you who are regular participants might find a little shocking, but I think because our panel really deserves the recognition and the presentation, I'm going to spend some time talking a little bit about who we are hearing from. We're very fortunate to have some key opinion leaders on this session, and so I want to spend some time letting you know who you're hearing from. So I'm going to start with Dr. Omid Hamid. He's actually supporting us as the moderator and as a presenter in this conversation. And I ask if you all please forgive me. Lisa, I'm just going to make you the host for now, and that way we can let people in.
Okay.
Thank you very much.
Mm-hmm.
Okay. So Dr. Hamid hails from Los Angeles, California, and as the director of the Melanoma Center and Phase 1 Immuno-Oncology Program at the Angeles Clinic and Research Institute, Dr. Hamid works to ensure that patients receive access to the most up-to-date therapeutics. Most recently, his role with the Phase 1 Development Therapeutics Program, Dr. Hamid has been instrumental in bringing new therapies from the investigational lab to the clinic for patient benefit. These therapies involve immuno-oncolytic therapies, such as PD-1 inhibitors and other checkpoint inhibitors, therapies against tumor angiogenesis, and targeted agents that block internal processes of tumor cells function, including those BRAF and MEK. Dr. Hamid's research focus includes manipulation of patients' immune system to attack cancer cells and maintain continuously elevated levels of immunity and discovery of novel therapies. His research began in melanoma and has now extended into paradigm-shifting trials for all cancers. Dr. Hamid is recognized nationally and internationally as a key opinion leader in immuno-oncolytic drug development and melanoma therapeutics. Through his role as the chief of immunotherapy and translational research, patients at the Angeles Clinic have benefited from first-class paradigm-shifting drugs. Dr. Hamid, as an investigator in some of the initial trials of some breakthrough drugs, serves patients in a very sensitive way in that, as you all know here, we try to make certain that the people who come here are sort of vetted, if you will, and genuine. One of the things about our community is we are concerned about our ability to trust providers and where we get information. And I'm excited that we take pride here in vetting, if you will, physicians. And so the professionals you hear here are people who actually care about our community and are actually interested in making a difference. So Dr. Hamid will be moderating our conversation tonight. Also, we're delighted to introduce Dr. Yvonne Knight at West End Dermatology Associates out of Richmond, Virginia. Dr. Knight is board certified by the American Board of Dermatology and has been practicing in Richmond, Virginia for over 35 years. She attended the University of Michigan, Ann Arbor, and received a bachelor's in science degree in pre-medical studies. She began a lucrative career in jewelry making, marketing, and major department stores. As planned, she matriculated at Howard University Medical School. And forgive me, some of my Howard heads out there. Dr. Knight will be pleased to know that we have some HBCU attendance here that's pretty strong, so we're really excited about that. Dr. Knight then entered a rotating internship, then residency in dermatology and dermatologic surgery at Howard University Hospital. For years, she was a medical news reporter for Health Team 6, a medical segment on the Richmond-based CBS affiliate, reporting on local and national health news. Dr. Knight is the lead dermatologist at West End Dermatology Associates and founder of the MediSpa West, a cosmetic spa for non-invasive treatment and rejuvenation of the face and body, is an associate clinical professor of dermatology at VCU Medical Center. Currently a principal investigator in research trials and studies, she has participated in numerous studies of investigational products to treat chronic and burdening skin disease to help improve the quality of life for patients. And we are delighted Dr. Yvonne Knight is with us tonight. Last but not least, of course, Dr. Jedd Wolchok, someone I consider a really close friend. I've had the honor of working with him for some time now out of New York, and we're delighted that he too joins us. Dr. Wolchok is the Chief of Immuno-Oncology Service, Human Oncology and Pathogenesis Program. As a physician and scientist, Dr. Wolchok investigates novel approaches for cancer immunotherapy and mechanisms of tumor cell, immune cell interactions. He's been at the forefront of cancer immunotherapy as an active clinician scientist exploring innovative immunotherapeutic strategies in laboratory models, as well as principal investigator in numerous pivotal clinical trials. Dr. Wolchok studied at Princeton University, where he received his BA, and also at New York University, where he received the MS, PhD, and MD. Dr. Wolchok specialized in caring for people with melanoma. As a researcher, he developed innovative ways to use immune system to treat cancer. He's been at the forefront of cancer immunotherapy as a clinician/scientist and as a principal investigator for several pivotal trials. He's been integral in the development of FDA-approved drugs that has extended life for patients, for some patients on some of the trials. And people who once given a matter of months lived are now living longer. And he maintains as a physician that nothing is more gratifying than being able to give someone his or her life back after cancer. We are delighted that Dr. Wolchok is with us, as well as the rest of the panel here. So without further ado, I'll step aside and mention only that most of us know the routine here. I will be remiss if I don't mention that I am delighted to see some new faces and some new organizations represented. We have a Second Baptist Church out of Pennsylvania. Thank you for joining us. You're welcome. Thank you. We have West Deep Creek Missionary Baptist Church out of North Carolina. We're delighted to see you. Thank you for coming. Also, we have St. Peter Baptist Church out of Virginia. We're delighted that you are here. So by all means, sit back, enjoy, and maybe write your questions down, or feel free to put your questions in the chat box. And as the presenters move forward through this, we'll try to capture as many as we can and collate them and address as many as we can. And as always, those that we cannot, we will send you email communications how to address that. Last but not least, we will, as an announcement, be resuming, of course, pending nothing too extravagant with the COVID vaccine happens. toward the latter part of the year, we'll be planning for our conventions, and very open to attending your national conventions, maybe with some of the speakers here or others. So by all means, feel free to remember us for those events. Thank you very much. And just a last mention, this is being recorded. And without further ado, I will transition the floor over to Dr. Hamid.
Thanks, Mark. It's truly a pleasure to be here to talk about something that's near and dear to us all. And I appreciate you putting me on the same level as Dr. Wolchok and Dr. Knight here, who have these phenomenal resumes and extended amounts of time of providing for the community. I think it's very timely to bring up this idea of what we're doing for skin cancer for the African American population, as we're coming to a time where even in the American Society of Clinical Oncology and many of the medical societies, we're looking at disparities, racial disparities in care, diagnosis, and follow-up. And the idea of skin cancers in not just the African American population, but the Hispanic population and people of color is a significant issue. As you know, the patients of color, their skin cancers are, even though it's less prevalent in these ethnic groups, they're diagnosed at a later stage. There's a decreased amount of knowledge about this. These patients are more progressed and stage for stage have a poorer prognosis. And what we're working through at this time is the understanding of why and how to change that. It's important to note that this is Melanoma Awareness Month and awareness of all skin cancers. And one of the patients that I work with who's very public about her diagnosis and public about her skin cancer journey is Dayanara Torres. A few people know her as that, a few more people know her as Miss Universe Dayanara Torres, but what happened to her and her recent diagnosis and her publicity about it brought forth something that's been written in our medical journals as the Dayanara effect, which is the effect of being public enough that it pushes a community, an ethnic group to becoming active in their own care. So this is an important thing to discuss, why these populations have less of a knowledge. I know why populations like ours, where we're darker, have a less use of sunscreen, less of an idea of how to do self-exams, why certain populations visit the physicians or the dermatologists less often. And because of our color, there's a lower index of suspicion of these diagnoses. As we move through this discussion, and I'll shortly stop and give the floor to Dr. Knight and Dr. Wolchok, it's important to know that in these communities, there may be different types of skin cancers, even a higher prevalence of different types of melanomas that we need to know about, and then a greater public awareness. And I think if we leave this meeting with one focus, it is that as individuals and as a group together, our ability to spur public awareness and education is the most important tool that we have. So with that, I wanted to thank you. I'm happy to be involved in this discussion and future discussions, and we'll give the floor to Dr. Knight. You're muted.
Are you hearing me now?
Now, yes.
Thank you, thank you. Thank you so much for allowing me to be part of this fantastic initiative. I feel right now what I'm expected to talk about is more so cases that I have come across in reference to skin cancer. Of the different cancers, melanoma being the dreaded one and the more difficult one to work with, we also have several that are easier and that are more frequently found in the general population, but Blacks and people of skin of color have more of an issue with melanoma, as we spoke of, as Dr. Hamid spoke of. Give you an example. I had a Latino woman come in, and she had an area on her buttocks. I had a PA working in my office, and he said, okay, well, that has to go. And so we'll plan surgery for you and we'll remove that. So when I go in to plan the removal with her on her surgery date, it is very obvious to me that that's melanoma, not just something we would easily remove. So we immediately put everything back together, never made a cut, sent her down to VCU, and they announced that that was a very rare type of melanoma. I think it was an equine source. I had never heard of that before. But it's interesting how when we do SOC, skin of color, when we do get a type of cancer, it is usually more involved, it is worse, it's harder to work with. And she was a very good example in my career early on. I had a gentleman came in probably in his early 50s, had children, wife, had a spot on his foot, and he said it was growing. I took a look at that and I said, it's obviously melanoma. Let's biopsy that, see if we can get it staged by way of skin. In other words, how deep in the skin is it? Because if it's real superficial melanoma, then we can approach it one way. Whereas if it's deeper, then we're probably going to have nodes dissected and check and see if it's spread to the nodes, and then plan a different approach. And that's where we're getting into more severe cases and having much more severe treatment that we have to have done, like at VCU, because I pass them on so they can get the best, of course. And I looked at that area and I said, this is probably going to, I didn't tell him, going to cause amputation of his foot and probably lower leg. I sent him to VCU. They checked nodes. He had not metastasized. They did not amputate the foot, but a big section of his foot. And I think he walks with a limp because he doesn't have the balance there, but he's alive. But it's a much more severe case. It's an example of how the disease progresses, and it does do that in skin of color people. It progresses more than you see in non-Hispanic whites. I've had several more. I've had one woman recently who had many moles on her body, and I had just mentioned to her, why don't you come in, let's do a full body skin check. And that's not something that people of color usually do. Non-Hispanic whites will come in very regularly for their full body skin check. But normally Blacks say, well, we don't get cancer, so no, I'm not going to come in for that. Well, they're starting to do that, thank goodness. And I'm finding some very interesting things. This one woman had on her buttocks in an area that there's no way she would ever see these moles, just a group of moles. They looked odd to me. I took 2 biopsies. They both came back as moderately atypical. Normal mole, mildly atypical, moderately atypical, severe, then you're on to melanoma. So she was on her way. I took those 2 moles off. They were fairly small. I had her come back. I said, let me check some more. They came back to be the same. The problem with her is that, do I try to take these 100 moles off of her? And she would be fine with the scarring to have the melanoma gone, of course, but we kept going and taking more off, and they still were being affected with the descent to melanoma. And then finally we started getting to some that did not show atypical changes. So she's doing very well at this time. She's coming back every 6 months now for her full body skin checks, because that's the only way we can try to keep up with them. We had another person, was a professor here at a university, beautiful woman. She took many vacations in sunny spots, developed a bump on her nose. I biopsied that. It was basal cell. So now we're not talking about melanoma. We're talking about one of the other common skin cancers like squamous cell carcinoma or basal cell carcinoma. Took the bump off her nose. It was basal cell, had to send her to Mohs. Mohs is the type of surgery where they take a layer, take a look at it, see if they left any, is it clear? If it's not, they go back, take another layer, do it again. So they keep you right there in the office and keep taking layers until they're able to get it all. And they did that, but then to reshape the nose of this fairly young professor here at a university, it was very tough. She's looking great now because we worked the scar to make it blend in and look much better. But it's really hard when you don't know that a bump that comes on you and is staying around, she wasn't there before, that you should have that checked out. Now, the question is, who checks that out? Many people go to the emergency department, emergency room, something quick and easy. That is not where you go. Many people go to the PCP. They're not trained in dermatology. That's not necessarily the place you should go to get the best information. And honestly, dermatologists make sure that they have a scope, a particular scope. It goes close to the eye, goes close to the skin, and you're looking beneath the level of the skin to see the types of cells and the organization or disorganization that's there. They need the scope in order to read it and tell whether that actually is a suspicious mole or not. So I don't see how the Mohs checks are done without a scope. And I don't see how you can, unfortunately, rely on people who have not been trained on looking through the scope and working with skin of color. There's so many nuances, so many differences that are important for people to know. I'll come back to that if I'm given the opportunity, if I haven't been shifted out the door. I'll come back to that as far as what dermatologists, how they need to be trained in order to be a better service to patients in a way that doesn't help with that disparity that we're dealing with.
Thank you for that. It's great understanding about how patients present and how follow-up is important in order to lend to a good surgical outcome, early diagnosis, and then a carefree existence. We should transition now to Dr. Wolchok to talk to us about how we take care of these if they're further progressed and the different types of skin cancers that we see. Dr. Wolchok.
Well, thank you, Dr. Hamid. And I first want to give my gratitude to Mark for inviting me to this extremely important discussion to join in with you, Omid, and also Dr. Knight. And I wanted to say that it's a real privilege to be here as part of this discussion today. As was mentioned before, this is Skin Cancer Awareness Month, so it's particularly appropriate that we have this discussion. I think that we are all very attuned to the need to make sure that we are paying attention to issues of healthcare disparities and equity. And so bringing more attention to the need for skin cancer surveillance in people of color definitely falls under that area of focus. As Dr. Knight said, there is a need for more surveillance for total body skin checks by qualified dermatologists who use the right tools to diagnose melanoma in people of color, hopefully early when it can be easily taken care of. But as Dr. Knight said, when melanoma occurs in Black individuals and other people of color, it can appear on parts of the body that are not easily examined during self-examination, or it can even appear on internal surfaces of the body. So believe it or not, skin cancer can start inside the mouth, inside the nose, in the back of the eye, which are obviously areas that any person cannot examine those spots on their own. So it's important to have a discussion with your primary care doctor of any new symptoms, but it's also important to, of course, bring any changes on your skin to the attention of a qualified dermatologist. Now, where physicians like Dr. Hamid and I come into the care plan is after Dr. Knight has diagnosed and hopefully has treated the melanoma, but sometimes it has spread to a distant organ. And that's where we get involved. And we treat melanoma with what's called systemic therapy, meaning medicine that's given by mouth or by vein that gets to wherever the melanoma cells have spread to in the body. Right now, there are two very effective modalities for treating melanoma once it's spread to distant organs. One is a technique called immunotherapy, where we give medicines by vein that activate the person's own immune system to recognize the melanoma as being something foreign and dangerous, like an infection, and attack it. And immunotherapies can be very effective in treating melanoma and causing melanoma to go quiet for many years. We don't know quite when to use the word cure, but there certainly are some people who have been alive and free of recurrent melanoma for 10 years or longer, and we're very grateful to be able to offer those treatments. Now, one of the real downsides to the use of immunotherapy for melanoma in people of color is that there can be the appearance of vitiligo or white patches appearing on otherwise skin of color. And this can be a tremendous emotional burden. It can be a societal stigma. We take this extremely seriously. And it's obviously a threat to people's identity to all of a sudden have loss of pigmentation. Thankfully, there are ways to combat this. So if anybody you know does have to receive immunotherapy and they are fearful of the development of vitiligo as a side effect, there are makeup formulations that can be used that can temporarily restore the normal skin tone. This is obviously a labor-intensive process for the patient to have to undergo to apply this makeup, but it is remarkably effective in hiding the areas of vitiligo. The other side effects that we see from immunotherapy, which affect everybody, regardless of what their skin tone is, are basically inflammation of different organs, the intestines, the thyroid and pituitary glands, the liver. All of these areas can become inflamed when we activate the immune system, and sometimes we have to use medicines like prednisone, which is an immune suppressing medicine, to calm down the side effects. The good news is that in most people we can reverse the side effects, and people can sometimes continue with their treatment, or maybe they don't even need any more treatment. The other form of therapy for melanoma that has been highly successful is called targeted therapy. This is usually pills. And what these pills do is in a subset of people with melanoma that have an alteration in a specific gene called BRAF, B-R-A-F, these pills shut off the signaling from that BRAF gene. And the BRAF gene is what drives the melanoma cells to make more copies of themselves. And so we're turning off that on switch with these pills. And they have also been remarkably effective in causing regressions in people with very advanced melanoma. As we get more experience with these treatments, the immunotherapy and the targeted therapy, we are now exploring their use in people with earlier stage disease. So Dr. Knight mentioned that in some people who have a deeper melanoma in the skin that have lymph nodes that may be involved once they're sampled, we know that those people are at higher risk of the melanoma coming back a few years later. So they are being offered either immunotherapy or targeted therapy in a preventative setting to try and prevent or delay the emergence of spread of the melanoma to other organs. But I think the best message to bring across is that primary prevention is exceedingly important and very effective. Our colleagues in dermatology have shown us how important early detection is. And I'm very gratified to hear that more people of color are now coming in for total body skin exams, because only through careful examination by a dermatologist can new spots, changing spots on the skin be diagnosed early. Hopefully, the patient can just be reassured that it's nothing to worry about, but if it is something of concern, it can be taken off with minimal morbidity and less risk of recurrence.
Thank you. That was a good way to discuss the ideas that are out there, what's holding us back, where a dermatologist fits in, and then the comfort in knowing that there are therapies out there to prevent recurrence and to prevent any further morbidity. But I'd like to take this into a grander conversation and ask Dr. Knight, in the African American and Black population, how do you explain to these patients about their moles or their skin and how to evaluate their themselves and when to come in? Because I would think that it would be a different discussion than you would have with any other skin type.
The Blacks, African Americans, Latinos, Asians, any skin of color person coming in, they're going to come in for a specific reason. And sometimes it's a little difficult to gear that conversation toward their general well-being skin-wise, and not just this one particular problem that they're dealing with that they want to have treated. But a lot of times you can get it in, and you can at least throw out a couple thoughts of other cases that you've had to give them something to remember so that they'll take it more seriously, and say specifically that I think within the next 3 months, take your time, make an appointment in the next 3 months, let's get you in, let's do this full body. And if we're not finding anything, then we can do the same thing, but further apart, like maybe every 2 years. But normally everyone should get an exam every year, and we go all through the scalp, and that's something that a person would never find on their own, something in the scalp and on some of the other areas. So they listen to it, they hear it. We have a lot of signage in our room also, not to overwhelm a person, but signs that says, for example, have you had your skin checked, and you have a person of color on that sign. So in other words, you put that together, that's a person of color. They're saying, maybe I need to think about having a skin check as well. So we try to reach out. And sometimes if you don't make the mark the first time, if they're not hearing you, go back again. And many times you start getting through.
Very good. And you talked about a specific type of melanoma. You mentioned acral melanomas. I'd like to just ask you to give us how you would describe it to your patients, and then Dr. Wolchok, the background of the difference of this and cutaneous, the skin melanomas that we see.
There are about 4 types of melanoma that we deal with, and the acral, ALM, acral lentiginous melanoma, is the kind that we expect to see more so on skin of color, people that have color in their skin. And you see this more so on the palms, the soles, and also on that the area right in between, right along the margin, both, again, feet and hands. And so many times if someone is sitting there, if I see something while I'm talking with them, I'll pull the hand up and I'll explain to them that we as Black people get moles on the hands and feet. They undergo a lot of trauma. You've got to take a good look at them on an ongoing basis. And what would be really great is if you're not coming in here, take pictures of them to make sure that they're not changing, because any change we do want to look at. But that area is something that is more unique to people of color. And what's interesting is that, not to dispel the attitude that we should have with sunscreens, for example, yes, we need to wear our sunscreen without a doubt. But sunscreen is not going to help those areas so much. So you've got to look there. You've got to look for the moles and watch them. Yes, use your sunscreen, but that's not the answer for that, nor is shade, like avoiding UV light, getting up under a tree or something. It's not relative to light exposure, this type of melanoma, whereas your other melanomas may be. They're working on that now.
Dr. Wolchok, anything to add?
No, I think I agree with everything Dr. Knight said, that, certainly in people of color, we do expect to see melanoma. If we do see it anywhere, on the acral surfaces or on, inner mucosal surfaces, like I said, the nose, the mouth, the genitourinary areas. I think that one important feature which Dr. Knight described at the end was that these melanomas that are on acral surfaces, and certainly ones that are on double covered areas of skin, like the buttocks lesion that she was describing earlier, we cannot point to sun exposure, right, as being important in those. And so, those are melanomas that, could not have been prevented with the use of sunscreen or with seeking shade. And what that leads us to is another conclusion. Those melanomas are less genetically damaged than melanomas that occur on sun-exposed areas of the skin, because sunlight damages the skin, it ages the skin, and it causes this accumulation of gene alterations. Ironically, all of those gene alterations may be one of the reasons why immunotherapy works quite well for melanoma, because the gene alterations make the melanoma look different from the normal skin around it, and therefore fool the immune system into thinking that the cancer is actually something foreign, like a bacteria or a virus, and not like a normal skin cell. That is not so much true with the acral melanomas. They still can respond to immunotherapy. They just don't respond as often.
Okay, so a whole different discussion to have with some of these populations. True, you can have skin melanomas, but very, very different, these acrals and these mucosals. For me, I find it interesting, the idea that certain populations have never been exposed to the idea that they are at risk for these malignancies. They have heard about everything else: breast, prostate, lung cancer, and it's just a difficult, and now the focus has come on education. Dr. Knight, what do you think is the best way to educate people or communities even before they need to come to see you or Dr. Wolchok or myself?
We can certainly do that in our offices, but a lot of times one person, one man or woman, can't do but so much. If you go high up, for example, in the dermatology organizational structure, if you go high up to our AAD and we push to get an actual reaching out to skin of color patients, to make them, to help to expose them to these issues that we're talking about, to make them more aware, to go and get these full body skin checks, and to know that around the hands and feet, those moles we've got to be more careful with and watch them more closely. I think that that organization, the AAD up top, spreading down over everyone and letting everyone pick up the ball there, pick up the reins and guide it in their community. But if one person, I've had several in my community where we had the skin cancer check. You come in, we'll just check for free, not register anything. But that doesn't do a whole lot. It doesn't really reach out and make a mark. Like I said, the AAD, if they would do that and sponsor a nationwide initiative, that would be wonderful. And I think now is about the time to do that, because they have been very, very receptive to many things, like the avenues that they can go down to attempt to train more dermatologists on Black skin. That's a big issue for us, because if we don't see pictures in the training process of what diseases look like in skin of color, then you can't make that diagnosis. So you kind of goes back and back and back. So, but if we can get up there with that organization, come down and start working with not only the skin of color patients, but also the dermatologists in recognition, I think that would be helpful.
What age do you initiate skin checks for these populations?
Teens.
The teens.
Teens. Mm-hmm.
Okay. I'd like to just make a point, as you were talking about the American Dermatological Association and others, that this is the best time to be a physician who focuses on this, which is disparities and education amongst different groups of people, different ethnic groups. The American Society of Clinical Oncology, Melanoma Research Alliance, all of these foundations, all of these granting agencies, including the DoD, et cetera, are just looking for people who are interested in steering their careers towards service to a particular population. So if anyone was asking, and I hope they do in the future, where's the best way to go? I think, and I know it's important, but you can be successful in steering your career into service for these populations. Dr. Wolchok, what's come through here is, again, a question about, is this inheritable, or can you get it from another person?
So great questions. So you cannot catch melanoma like an infection from another person. There are some families where melanoma does run through the genes, and you see it in every generation. It's not very common, but if you do notice that there are multiple generations in the same family where there are cases of melanoma, then that's something that could be discussed with a genetic counselor. There's one particular syndrome that is called a loss of the gene P16, which causes a high frequency of melanomas. One of the breast cancer syndromes, the so-called BRCA or BRCA syndromes, which are associated with breast and ovarian cancer, BRCA2 inheritance can also lead to a higher incidence of melanoma. Now, if you do notice that there are multiple people in the family with melanoma, the good news is that you don't need to do anything remarkably different than we already spoke about. We just need to ensure that people are screened by an experienced dermatologist on a very frequent basis. And sometimes, I believe Dr. Knight spoke about the use of photographs. Sometimes people who are very high risk, either because of family history or because they have many, many moles, they will often undergo a procedure called total body photography, where they're given photographs of their whole body to take home with them so that they can do self-examination very easily to compare new spots with old spots, and then bring things to the dermatologist's attention very quickly.
Thank you for that very nice review. Now, Mark, I have left you out of this, but I'm going to bring you back in to take us home. You have the power, as you've shown, to bring groups together, whether it's churches, whether it's medical groups, whether it's significant physicians with a national and international reach like Dr. Knight and Dr. Wolchok. Where we will leave this meeting is understanding how you feel that you can best use your power and move this discussion forward in an educational way.
Thank you for that recognition. I really appreciate it, but I have to certainly be transparent about the amount of effort that goes into this and the efforts we've been doing throughout the years. Certainly, I have been, I guess, the face of it, being able to straddle the fence, if you will, as a medical science liaison for biotechnology companies and being very active in my community. But there are several people, even on this call here and who are not here, who will listen to this as soon as they get a chance, this recording, who have been integral in helping us spread the word that the Black and African American communities, the spectrum of cultures, have a lot of work to do if we are to address our health outcome disparities. We recognize that there are systemic health outcome disparities that exist that have maybe been sponsored by or initiated through systemic practices that we argue now should be behind us, in that there are tools and mechanisms for policing. There is the obvious example of what we are now, whereby we should talk within our community with people we trust, be it our pastors, be it our relatives or our colleagues, or people like me and Lisa and others on this call, who are also professionals who live and work and play and among us. And so all of us should be comfortable either coming to me, coming to Lisa, anybody at Berea, of course, and saying, look, I have this issue, this health issue that I'm concerned about. Can we talk about this? And you can do so in complete, as everyone knows, autonomy and private. No one has to know you ever mention any topic to us. And then I and other people that work with me in this will approach our network and sphere of influence, like the brilliant doctors who, as I alluded to earlier, who clearly care. I mean, for Dr. Hamid, he's in the middle of his day out in LA, and I'm sure he has a patient load to address. Of course, Dr. Knight is in Virginia, and this is the evening time for her. And of course, Dr. Wolchok is in New York. This is evening time for him. So these are the types of people who do view our communities as groups of people who do matter. And so sometimes, although media will encourage us to group and be divisive or divisive and cause us not to trust certain groups of people, but in those circumstances, what I and my colleagues here are trying to do is to represent a bridge so that we can say, okay, if you don't feel confident, or if you don't have the access that you think is appropriate for you to feel comfortable to make sure you're getting the best care, come to us. Allow us then to reach out to our network of professionals like the brilliant minds we have here so that we can bring to you the resources you need. And then guess what? More than anything, and everyone knows that I'm passionate about this, let's be serious about making a change in our culture. A lot of the things we experience sometimes can be abated if we stop saying, well, I got this from grandma, or I got this from mom, and mom or grandma did not have a strong resource of information themselves. So we're trying to fix that. We're trying to say, no, let's get solid information, correct information, modern information, and then make some changes within our community. So, I mean, with that said, I think there is a question. I'd be remiss if a person asked a question bold enough to do it right here on the platform, and then I didn't give them that view. But within the next few minutes before I close, I would like to give Alexandria, and of course, I think it's Carol, an opportunity to ask their question. And I'll just read it if it's okay. And if that's okay with you, Dr. Hamid. From Alexandra, any trials needing Black and brown people for further education or research? I guess that's a broad question, probably for Dr. Hamid or Dr. Wolchok, but certainly Dr. Knight also, if there are trials that may be earlier in the stage of disease development. So I'll leave it to the panel to answer that. Whoever wanted to go first, I'll give it to Dr. Knight first.
When you say trials, do you mean for melanoma, or do you mean just trials for some of the burdensome skin disorders we have?
Skin disorders that we have, like any type of dermatology related, yeah.
Vitiligo in particular, we are doing trials in my office, and the ones that we are about to embark upon include vitiligo as well as alopecia areata, the hair loss, and then atopic dermatitis, better known as eczema. Those are some of the trials that we're doing. We have done some already as well, completed those. For example, dupilumab, Dupixent. We did that trial for that drug to come out, and that is excellent in people who have very severe eczema and atopic dermatitis. We're getting ready to do another one also. So yes, the trials are there. Sometimes you have to reach out. If you call my office, for example, I'll try to steer you. I'm not sure where you are, but try to steer you. But normally there are locations that are sources where you can call and find out about trials in your area. We do advertise, the companies advertise also. If you can somehow get the name of a company or just find that source of what they're having in your community where you are, then you can become part of a trial.
If I may add to that, Dr. Knight, if in the event, as I alluded earlier, if anyone on this call or anyone you know is, if your doctor said to you, you are a candidate for a trial, and for whatever reason, you've heard the sayings, you know, I don't want to be a lab rat, or I remember some things that have happened historically. If for any reason, feel free again to reach out to the Black and African American Health Reform Initiative. We will employ our scope of resources and get you an answer that you can be informed and understand what the trial is about. If it applies to you, you can get a second opinion. You can do what it takes to ensure that that type of path, so that you feel comfortable if that type of path is best for you. That's what we're here for. So I think Carol, does that answer your question, Alexandra?
It does, thank you.
Excellent. So I think Carol had a question there. Carol, you want to ask it? You want me to read it? Carol said I read, okay. Do I need to pay attention to my skin to determine if I need to see a skin doctor or specialist? Do I need to do that?
Yes. Hair, skin, and nails are that exterior that dermatologists work with and specialists in those areas. So if you have a problem there, the way to get to the diagnosis and the treatment without wasting time, without wasting effort, it would be to see a dermatologist. And probably reading reviews on the dermatologist as well, because not all dermatologists are trained in the same way. And you do want one who has the knowledge of the nuances and so forth of skin of color.
Thank you for your question. In the 5 minutes we have left, again, I want to give everybody a chance. We have time for maybe one more question. Does anyone want to unmute and ask that question or type it in the chat? You can do so privately to me or Lisa Overton. We can share it without disclosing who you are, or you can just unmute and ask your question. I'll give us a few seconds while I, go ahead.
I have a question.
Sure.
Mark, this is Carol. My question is there, would there be itching at the site where there could be a potential problem?
No.
No.
May I speak up? As far as melanoma is concerned, are you referring to melanoma?
Yes.
Totally asymptomatic usually, until it becomes, for example, if it's catching on things, or when you sit down, you feel it, or some by chance symptom like that. But normally, no, totally asymptomatic. You don't feel it or know that it's there unless you look at that mole, see that, wow, it has changed. And if you suspect a
I
mole,
think we lost her.
can you hear me?
Hello?
I can.
And
Yeah.
if you suspect a mole, start taking pictures of it and take the pictures with you to the dermatologist. And this is what it looked like last month. This is what it's looking like now. That is very, very helpful when you do that. But no, you have to have that air of suspicion. It's not going to knock on your door and say, I'm changing, or there's a problem here.
Although there needs to be the point made that anything you see that is different, becoming raised, itching, bleeding, widening, you know, those ABCDs that we're talking, asymmetric, the borders are changing, the color is changing, the diameter is growing, or it's evolving, that's the E, evolving, then that's something you need to take to your dermatologist, your physician, and say, look at this.
Thank you both.
By all means, be diligent. You know, as Dr. Knight mentioned, this is a kind of thing, unlike some of the other diseases we've talked about, this is a kind of thing where when she was saying asymptomatic, she's saying you may not have any signs. There may not be, you may not feel anything. There may not be anything that says, hey, there's a problem going on here. So you have to monitor your body, pay attention to your body. Like you've heard us say 1,000 times, you know, pay attention and speak up. If not to someone within your family, for we do as a culture have difficult times sharing what we believe is personal information with family members and things like that. As I've said, you always can email us anonymously, and we will be more than happy to get you information and even connect you with someone who can help address your issue. We have about 3 minutes more, and I want to use those minutes to beg that we continue this work, not only because I have a deep passion for ensuring that each and every one of you live your best life, not only because of that, but because this is the time. This is 2021. How many of us are old enough to remember that when we were watching the Jetsons on TV and people were talking into their watches and riding all these what we thought were space machines? Time is up. There's no more time to wait. There is no more tomorrow. There's no better day than today to change the cultural practices that inhibit you from prosperity, inhibit you from growth. And now you are without excuse, right? Biblically, we hear that, at least on the Christian aspect of our spectrum of religions. We hear, you know, without excuse, you have no excuse at this point. That said, by all means, we are here for you. Use the website, contact any member of the bereaved family, which you are now a part of. And so we want to thank the brilliant minds and Dr. Hamid and Dr. Knight and Dr. Wolchok, and thank them for their time and their passion and love for our community and the work they do every day. As we all go out and endure what we have to with regard to COVID and our family challenges, and as we try to reacclimate our lives to what seemed to be a pendulum, a moving target of, oh, do I wear a mask or do I not, and all this, we can certainly address those kind of questions too. But as we do that, I encourage you to live every day with vigor, because don't wait tomorrow for what you can do today. Enjoy your life, but do so with information that you have available to you. I love you all. God bless you all, and have a fantastic evening.
Thank you.
Thank you, everyone. Thank you.
Thank you. Very, very well. Very good presentation. Thank you.
You're welcome.
Thanks, Mark.
You got it, buddy.
Good seeing everyone.
Thank you. Great session.
For attending. Thank you for attending.
Good evening.